My name is Michelle Graham. I am an interventional cardiologist at the University of Alberta. I'm going to be speaking to you today about aspirin in patients with previous percutaneous coronary intervention, or PCI, who are undergoing non-cardiac surgery. This is the POISE-2 PCI substudy. I have no disclosures. Worldwide, 200 million non-cardiac surgeries occur annually. Of these, 10 million patients will experience a major vascular complication, leading to increased mortality, hospitalization, and costs. Providers commonly encounter patients with previous PCI who are now undergoing non-cardiac surgery. These patients are known to be at increased risk of perioperative complications, and uncertainty remains about the effects of aspirin in patients with prior PCI who are undergoing non-cardiac surgery. The POISE-2 trial randomized just over 10,000 patients undergoing non-cardiac surgery to aspirin versus placebo. In this trial, aspirin did not prevent the primary endpoint of death or myocardial infarction, but increased the risk of major bleeding. At the time POISE-2 was designed, the steering committee did not expect that patients with previous PCI would be randomized, and therefore did not pre-specify a PCI subgroup analysis. However, 470 patients with previous PCI were randomized, and we therefore undertook analyses to determine whether a subgroup effect was present in patients with prior PCI. POISE-2 was a blinded 2x2x2 factorial trial of aspirin versus placebo and clonidine versus placebo. Eligible patients were over the age of 45, undergoing non-cardiac surgery, and at risk of vascular complications. We excluded patients who received a bare metal stent within 6 weeks, a drug-eluting stent within 1 year, and those who took aspirin within 72 hours of surgery. Patients were randomized to 2 aspirin strata, the initiation stratum and the continuation stratum, for those who were on aspirin chronically for at least 6 weeks prior to surgery. These individuals stopped their home aspirin a minimum of 72 hours prior to surgery, and on average, 7 days before. The primary outcome was death or non-fatal MI at 30 days. The prior PCI subgroup consisted of 470 patients randomized at 82 centers in 21 countries. 234 were randomized to aspirin and 236 to placebo. 30-day follow-up was 99.9% complete. The baseline characteristics of these two groups were very similar. Age was around 67 years, 22% female, 59% undergoing major surgery, and 30% of patients were diabetic. The vast majority, 86%, were in the aspirin continuation stratum. In this prior PCI subgroup, roughly half received bare metal stents, 25% drug-eluting stents, 12% unknown type of stent, and the remainder were either angioplasty alone or uncertainty as to whether or not a stent was used. The median duration from PCI to time of non-cardiac surgery was 64 months. For the primary endpoint of death and myocardial infarction, the interaction p-value is significant, which suggests that the results for patients with prior PCI compared to others were in fact due to real differences rather than chance alone. In the overall trial, there was no difference in the primary endpoint for aspirin or placebo. However, in the prior PCI subgroup, the rates were 6% in the aspirin arm and 11.4% in the placebo arm, with a hazard ratio of 0.50. These are the individual components of the primary endpoint. For myocardial infarction, the interaction p-value is again significant at 0.021. There was no effect on myocardial infarction in the overall trial or those without previous PCI. However, in the prior PCI subgroup, the MI rate was 5% in the aspirin arm compared to 11% in the placebo group, with a hazard ratio of 0.44. In contrast, for death, the interaction p-value is not significant, suggesting that the overall trial results are most informative, and there is no support for a subgroup effect. This Kaplan-Meier curve visually demonstrates the differences in the primary endpoint between groups in patients with prior PCI. In terms of safety outcomes, once again, the interaction p-value is not significant, suggesting the overall trial results are most important. In the overall trial, there was an increased risk of bleeding with a hazard ratio of 1.22. We also looked within these 470 patients with prior PCI based on type of stent, timing of PCI, and whether antiplatelet medication was received within 7 days before surgery. All interaction p-values were negative, again, not supportive of a subgroup effect. However, these analyses are of low power, and we cannot exclude that there is a subgroup effect for these characteristics. We also performed a subgroup analysis based on a history of coronary artery disease to assess whether the PCI subgroup effect was simply reflective of coronary disease. In contrast to the PCI subgroup analyses, the analyses for both the primary outcome and myocardial infarction demonstrated no support for a subgroup effect. In conclusion, for every 1,000 patients with prior PCI, the use of perioperative aspirin will prevent 59 myocardial infarctions, but cause 8 major bleeds. Among those with prior PCI undergoing noncardiac surgery, perioperative aspirin may be more likely to benefit than harm patients. Thank you for your attention.